and trying to improve upon it. To define the uniform benchmarking, of course, that is required for the quality of services which are accountable and responsive and sensitive to the needs of the community as such. To specify the minimum assured standards and achievable. So this time we have got a different kind of concept. There are essential and desirable. Because we know various states are different stages of progress, and progress as such is incremental. The funds have been given, and as you know, in addition to the NHM funds every year, the PM of and Finance up to 25-26 currently. So, and targets have been given for every year as such to various states. So, incremental progress, looking at that, we have defined these standards as essential and desirable. And again, health system strengthening component, that has been looked at to provide guidance of the entire health system strengthening. The acceptable standard of quality of care, so we are linking with NQAS. I'll come to it how we are linking with the National Quality Assurance Standards. And of course, it also facilitates the monitoring and supervision, provides a governance and administrative mechanism tool to the administrators at all levels, including the facility in charge. The approach is now has shifted from the input-based, which was largely, to output-based approach. Similarly, in the PIP also last year, if you any of you are aware, we reduced the number of lines, budget lines to less than 200. It used to be more than 1,000 and all a few years ago. So, and we are when we are, trying to look at the progress of the states, it's more of output and outcome oriented rather than input oriented. We are not trying to say that what are you spending at in minute details. We're looking at what you're going to achieve, and we're later on trying to measure it. Similarly, for this IPHS approach, it's a reverse kind of planning which has been given now to states. But you look at what are the outputs and outcomes you want to achieve, and then try to reverse calculate your infrastructure requirement, your HR requirements, equipment requirements, diagnostics and drugs requirement, and so on and so forth. So that's a different kind of approach which has been taken as compared to the previous versions. And similarly in HRH, I've given an example that even the facility is at a smaller level, but the workload is higher, one can have more HR. It's not that only that money of HR is required. So that's why essential and desirable, that is also there in the guidelines. These are the various components. The ones with the asterisks are the ones which are recently added. The accountability and operationalizing of this, the quality, monitoring and compliance, and clinical governance. Compliance word why I'm using it because we are not using certification for IPHS because we already have a certification system of the quality assurance standards. We don't want to create another parallel system for certification where we have another team of assessors for this. This will be assessed by the facility itself. In case of initial requirement, they may have a block level or district level or state level, people from helping them and nodal officers can help them. Otherwise, every facility should be able to assess themselves for its compliance. These are the few components. Essential services at the forefront with the added specialities, even like psychiatry, dermatology, and all have been added. Critical care, of course, critical care blocks are coming up in 602 district hospitals, 50 to 100 bedded, depending on the size of the population as such. The HRH has been linked with the services. Because shift based, it's not that we have only two staff nurses and we expect the facility to work for 24/7. So that kind of approach has been taken. And availability of GDMOs, that was another major issue challenge earlier. So that has also been ensured that shift based or GDMOs are available all the time. And of course, staff nurses, one of the important components of the health system as such. The other parts are disabled friendly or specially able friendly infrastructure. So that has also been looked at in this by providing the complete designs and diagrams of each and every kind of facility. Green and climate resilient infrastructure, looking at the national program also of climate change. Again, IPHS compliance has been introduced, which I mentioned earlier. Free drugs and diagnostics, as per those guidelines only, they have now been made part of IPHS. Instead of those being standing alone in isolation, they've been made part of the IPHS. Without that, no facility can be IPHS compliant as such. And of course, patient-friendly services which have been augmented. Again, looking at the grievance redressal. And we're also trying to strengthen the Mera Hospital also at NQAS, which will be linked with the IPHS checklist as such. We are providing support to states for ensuring this compliance through the conditionality framework. Again, NHM funds what they are getting, the conditionality framework, that is also now output and outcome oriented rather than input oriented and process oriented. So that is links with that. And the outcomes which are envisaged are improved accessibility. And of course, when accessibility is improved, when the quality is improved, the acceptability is also improved. So that's the kind of...
Studies show that the people who are born poor or in the middle class, they rarely become wealthy. Now, there could be many reasons. It could be because of society, it could be because of government, it could be because of economy, there could be many reasons. But one reason, which very few people understand, that reason is because of the lack of vision. Most of the people do not have the big vision. Now, a lot of people watch my videos and they build a perception. He is from rich family. How will he understand us? What does he know about being in poor family or middle class family? What is his experience? A lot of people don't know that I was born in a poor as a truck driver. I lived in slums. We did not even have toilets in our home for so many years. From there, I worked hard in the job, and I worked there for 16 years, making 3 lakh a month. So if you see in total, more than 35, 36 years of my life, I was in a middle class. In only the last 3.5, 4 years, I became a multi-millionaire. Now, how did I do it? Do you think I'm great? Do you think I'm wonderful? I don't have business background. The reason why I got to where I am is because my vision got expanded because of my mentors, Grant Cardone, Dan Lok, and I found the process which I followed step by step by step by step. And today, I can live this great life, travel anywhere, drive my Ferrari, live in an 11-bedroom home, and I'm my own boss. If you're watching this video and wondering, can anybody do it, Dave? Is it possible for anybody to live that life? Is it possible for somebody from a middle class to becoming free and living their passion every single day? Is it possible for anybody? The answer is absolutely yes. How is it possible? It is all based on the process. If you know the process, which I know, and my mentees know how they have become successful, how I have become successful, if you know the process, anybody can do it. The question is, do you have open mind to learn the step-by-step process? And if so, I'm happy to share all my secret with you. I will teach you things that you would never learn in your formal education ever. In just 3.5 hours, your mind will be blown and you will see the big vision and big picture and believe that it is possible for you as well. So don't waste time because I may not do these webinars again. So click the link, join the masterclass where I will teach you 7 process of building a business around passion. Click the link. I will see you in the masterclass. He looked right in my eyes and he told me, son, make sure you study hard so that you don't have to do what I'm doing today. That line of my dad was stuck in my mind and my heart. For my whole life, I've been told that what I can become and I cannot become, but no more. I reached a point where I said, you know what, my life is starting to change. Now I'm going to give back to the world because I know there are more than 260 million Indians living in average middle-class families. I said, I'm going to be that one. I would make sure that nobody loses their precious stuff. The US aspire to work in the United States of America. But don't worry if you're not a computer science engineer. Miles now has cracked the puzzle for finance and accounting folks to work in the US for 3 years. How's that possible? Simple. Enroll with Miles for the CPA program, and Miles will help you pack your bags and fly to the US for a 1-year Masters in Accounting program. So that by the end of that 1 year, you have both your CPA and your Masters, and you're all set to work in the US. Now, a typical Masters in Accounting program awards only a 1-year work permit. That's where Miles comes in. We worked with the US university partners to have business analytics integrated into these accounting programs so that they are now STEM certified, and you get the same 3-year work permit that engineers do. And with a record 96% F1 visa acceptance rate, we now have a huge number of Miles CPA alumni in the US. Let's hear what a few of them have to say about how they're living their American dream.
Initially, it started with Miles pursuing CPA.
I had not expected, being from commerce background, be able to come to US.
I have done my chartered accountancy back in India and masters in accountancy with analytical track. That's something advanced than what I have studied before.
I would encourage anybody to take up this program because there is a crunch for accountants here in the US. So it is the best time to come.
Miles education helps me a lot throughout my whole journey from the day one.
Admission process was very smooth only because Miles was there in every step.
Receiving the admission letter was the happiest moment.
I have to thank Miles for being very, very supportive, who has ensured that I don't get tensed for visa interview, because visa interview is one of the toughest things.
I got a pretty good amount of scholarship.
I was very excited when I received my visa. First, it took me 10 seconds to really digest that, yeah, the visa has been approved.
I was shouting in my house that I actually made it into the US.
Miles made it happen, and yeah, I was very happy because of that, that I'll be able to start a journey here in US.
So whether you're looking at relocating to the US or Canada, or staying back in India to work with a big four or multinational company, you've got only miles to CPA. With the US CPA, even freshers earn 10 lakhs per annum in India, or more than $60,000 in the US. All this with only 4 exams and in less than a year. Are you ready?
Things are going up so that we can be better prepared for the future. 2010, Kerala,
who will be telling us the journey of National Disaster Management Act policy and plans. Welcome, Dr.
thank you, Chair and Co-Chair. We listened about the Public Health Standards Act policy, international health regulations. And the linkage with disaster management is equally important, and COVID-19 actually taught us that without the implementation of the provisions under the Disaster Management Act 2005, we would not have succeeded in containing or controlling the COVID-19. I can take you back to our journey, which started way back in 1990s. I remember the day, 22nd December 1989, when the UN, there was a discussion about why developing nations are not able to progress well despite all their best efforts. And the outcome of the deliberations was that it is the disasters which rode away the benefits of all their efforts. And so this is how the journey started from the global level through the United Nations. And they declared an international decade for natural disaster reduction, and Japanese, which were prone to various types of hazards, they came forward. They were economically better and suggested the UN to have World Conference on DRR, the first World Conference which came up in Yokohama in May 1994, actually led nations to think about establishing a dedicated system on disaster management. And at that time, the government of India, at that time it was Ministry of Agriculture and Farmers Welfare, which was the nodal ministry on disaster management, actually started a National Center on Disaster Management, which now got upgraded and got the status of a statutory body under the Disaster Management Act 2005. Later on, we had a lot of instances of disasters within our country, and they turned out to be the key turning points in the history of disaster management. In fact, the 1998 Malpa landslide, which brought the issues of landslides at the national level, and thereafter the 1999 Odisha super cyclone, which took place on 29th October, and the 26th January 2001 Republic Day earthquake, followed by the tsunami, which took place on 26th December 2004, and the 8th October 2005, the earthquake which shook our Jammu and Kashmir, which was struck in Muzaffarabad, and so on. So it happened that the High Power Committee, which was constituted at that time in 1999 under the chairmanship of the former Secretary Minister of Agriculture, C.J.C. Pant, actually recommended National Disaster Management Framework and also a bill to be placed in the Parliament. And this bill was placed in November 2005. Within a less than 1 month period, the bill was passed from both the houses and signed by our Honorable President. And it became Act 53 of 2005, which is of importance to us. It has 11 chapters and 79 sections. This act actually gave us legal empowerments to undertake all kind of activities, functions, and roles and responsibilities for different authorities, under which even our NDMA, under the chairmanship of Honorable Prime Minister, was constituted. We had the presence of today one of the members here, and also we had the state disaster management authorities and the district disaster management authorities, which took up all the responsibilities during the COVID-19. And as because of those acts, that act actually also outlined the financial provisions in terms of National Disaster Mitigation Fund as well as response funds. And these funds were in fact a very much help to the built up of the infrastructure during the COVID-19 as well. So all these issues are there, and subsequent to that act, after the constitution of NDMA, NDRF and NIDM at that time, we have got the national policy, which was actually formulated by our NDMA way back in 2009, 22nd October, I remember, when it was released. And that policy actually gave us our vision of disaster management in terms of developing a culture of risk assessment, prevention, mitigation, preparedness, and response, and efficient recovery through a culture as well as state-of-art technology, making it proactive rather than reactive, which was the earlier approach in terms of ad hoc and piecemeal. May I request kindly to scroll the slides also for the audience purposes. I can tell you many things without even these slides. But the history is that with these developments, the global developments were also taking place. I told you, YOCOMA in 1994, May, YOCOMA Strategy for a Safer World came, and Government of India established the dedicated DM cells in our ATIs where our functionaries were being trained, and also in our SIRDs and National Center. Then what happened after a decade? The government of Japan, okay, thank you, also took the second workshop, which was held at Hyogo, from where Hyogo framework of action, the 5 action points which were important and vital for undertaking activities related to DR were taking place. Then subsequently, in 2015, from 14th to 18th of March, the third World Conference was held at Sendai. Sendai, you remember the place where that 11th March 2011 tsunami had taken place, which are termed as triple disaster. These all were turning points from the global to the national levels. We had the ISDR from the UNDR, now UNDRR office, and at the national levels, all these bodies and the allocation of the funds. Parallelly, our Planning Commission and Finance Commission also worked on it, and the 15th Finance Commission brought out its dedicated chapter for disaster management framework, and also established National Disaster Risk Management Funds, not only for their response and mitigation, but also for capacity development. So these are the scenarios which took place, and these scenarios actually came out as a product of this information which is being shared on these slides, that we had the data which indicated over the past 2 decades, from 1980 to 1999 and from 2000 to 2019, the number of incidents and their impacts have actually increased despite all our best efforts. So that actually indicated our challenge and the need to strengthen this system. So at Sendai, the 4 priority actions which were proposed actually proposed investments and strengthening of the governance for DRR, besides the understanding of DRR, as well as taking the lessons forward from the recent and the past disasters. Why? Particularly in our country, this histograph actually shows India is very much vulnerable and prone to variety of disasters. HPC outlined 32. Later on, tsunami was also included, but we have many more. For example, I can cite you, don't quote it otherwise, but the recent example in terms of, we are talking of coalition of disaster resilient infrastructure, only in terms of physical resilience, but not in terms of soft resilience. For example, the target which was done at Thames in terms of the hacking of that server actually caused that problems, which is also one of the important issues. And that's why NIDM established a Center for Cyber DRR as well. So these are some of the issues which we need to take care, and aggravating factor for all this I just listed are our urbanization, changing climatic conditions, which was discussed in COP26, where the concept of life was introduced by the Honorable Prime Minister, and in the COP27 also, which just finished during the last month. And also, in terms of the growth of the population, we are going to be the first one rather than the second one in the world in terms of our population, absolute population. And the environmental factors, which has been discussed by the Honorable Minister during the inaugural speech, that we should not disturb and should try to live in harmony and should change our lifestyle. So these are our main parameters. Next, please. Disaster management cycle. Rather than reactive, ad hoc and piecemeal, we should not wait for disasters to happen and start our work. So we are now planning strategies. We are now meeting together and enhancing our capacity. Just 2 more minutes I will take. Next, please. So this is what I talked to you, and this policy I talked to you till 2009. Subsequently, we have also got after the Sendai, the 10-point agenda from our Honorable Prime Minister in the first post-Sendai Asia Ministerial Conference, which was held from 3rd to 5th of November 2016 at Vigyan Bhavan. And at that time, he actually amalgamated all the 3 international agreements in terms of climate change, sustainable development, as well as disaster risk reduction. And the 10-point agenda is being followed up by Government of India in various forms in terms of DRR and development. And also the NDMA took up its efforts for having a national disaster management plan, which was first time prepared in 2016 and revised according to Sendai framework in 2019. Now the states are also undertaking these SDMPs. So the planning, policy, act are now in place along with the funds to undertake necessary actions. Now our technical inputs, our experts, they have to contribute. And this integration, as it was said in Sendai, it has to be all-inclusive and ecosystem-based approach is to be followed. As the Honorable Minister also said, different layers of society and sections of society have different types of sensitivities and the vulnerability. So we are undertaking all this. Table is actually showing those 32 types of disasters under 5 different categories. So you can see the chemical and industrial as well as biological, radiological and nuclear disasters have been kept together because CBRN is one of the areas which is one of the most difficult areas in terms of disaster. And normally they turn into crisis and it is dealt through NCMC, not directly through disaster management. So we have to actually find out this thin line between emergency, crisis and disaster management. That's why we have to know about the system which deal with these issues. And these are the chapters, and in just mentioning some of the things which actually were important. One of the issues which were talked in the inaugural was the Epidemics Act 1897, and later in 2020 we had the Epidemics Ordinance. But the DM Act actually empowered us for the lockdown, which was not otherwise possible. And also controlling the violence against the frontline workers. All were done through the chapter 10 under the offences and penalties in the Disaster Management Act. So this is what I feel must be known to everybody to undertake all those activities. Next, please. This I've already spoken. The plan is available and different guidelines which has been released. And specific guidelines on biological disasters, specific guidelines on communication systems, specific guidelines on disposal of dead bodies, mass casualty management, and different other type of hazards, functions, and cross-cutting issues, including the community-based disaster management, all are there. So we can get some ideas from them, and also the public health standards and the policies which are available from the states and need to be formulated at the central level. And these are some of the important points which were mentioned in the public health emergency and biological guidelines. And coordination is one of the key. I've dealt with maybe more than 24 of disasters and post-disaster scenarios also. And coordination is one of the common gaps which have been found across every disaster. And we need to follow this. So we are through capacity development, which is one of the mandate of NIDM under the Act, is not only training, but even addressing the non-training needs. Behavior is more important than just knowledge. And knowledge without practice is not going to bring any benefits. As said by the Honorable Prime Minister during the Climate Action Summit, that ounce of practice is much better than tons of preaching. So all these are the steps which we are now following in terms of PHEDM. I told you one of the modules which we developed, and the two other modules we are in progress, and we are working and building partnerships, networks, and will try to bring every relevant concerned stakeholders on that one platform, one approach. As said in the G20, Vasudhaiva Kundakam, one earth, one family, one future. Thank you. And with this, I will end up here. If any questions, we will follow it. Thank you. किसी शायर ने कहा ना, मंजिलें उन्हीं को मिलती हैं जो सफ़र अख्तियार करते हैं, ऐसे मुसाफिर का तो रास्ते भी इंतजार करते हैं. तो we started our journey towards risk reduction and resilience, and destination is awaiting us for a disaster-free and resilient nation with zero calamity. Thank you.
Thank you very much. Nice presentation. The last topic of the first session on one-health approach. We said we discuss very novel sessions for the session. Talk on that.
Yeah, now afternoon. So good afternoon, all of you. I hope you are not sleeping. Many of you are engaged in your mobile phone. I don't know what is the purpose of offline and online, same, all over. So half of the time we are stuck with the disaster ourselves, always with the mobile phone. So I don't know how much we give importance to the issues. I am grateful that respected Shivlalji chairing this session. We have our friend Dr. Pradeep, Surya Prakash has already spoken. Rajiv has called me, so thank you very much, Rajiv. And he is lead emergency management, and hopefully he'll do something. Yeah. So today is the World Soil Day, correct? So we are talking about soil. Someday the water will come. Other day, some environment will come. Air day, these all things are there. We are just, talking in isolation, and that's a big problem. That is why this is very nicely written, Vasudhaiva Kundakam. We don't follow it, and we are just, these are the philosophies, we don't do it. So, this pets, we have pets like dog and cat. Actually, dog is a oldest companion. It's a domesticated animal. Like the human being has created this dog. It's a very interesting one. And still we have not learned that animal is part of us. There are so many. So how to leave such kind of creatures on the same earth? I'll just speak really fast. Which chal nahi raha hai? Yeah. So disaster, you already know that there are different types of disaster, and we are always seeing that animals are there with us, and they are also equally suffering, dying. Yes. And then we have diseases due to, after the disaster. Well known, I'll give a few examples, like the leptospirosis in Kerala. Then we have, this is another example of human cases of leptospirosis post-flood in Nicaragua. And then we have this another example of the, cholera epidemic. To keep pets safe and healthy after hurricanes, that's also advised, because they also equally suffer. These are all animals which are, related to different kinds of diseases after the disaster. So we have evidence, and we have to think that, zoonosis is emerging, and they are creating themselves as pandemic type of situation like we have recently. So many. For last 50 years, might be having more than 50, type of epidemic and pandemic. And the COVID is the example. So this zoonotic disease, is reality, and we give very less importance. It is just because they are actually culturally and socially, associated. That is why they are significant for us as a civilization. And they are using the same food and clothing and culture, play and entertainment. So they are equally part of everything. The ban and restriction of international trade can lead to so much loss, and we already know that 80% of world total drought power is because of them. So 54% of energy used for crop production is contributed by cattle. So just see that development, how much development is linked with them. So if they are damaged or they are not there and we are not looking after, then definitely we are suffering from the emerging and re-emerging diseases which are common. So the mortality is very high, it is already known. We have the livestock which lead to so much problem. If the animals are suffering, then we have occupational hazard which increase multifold. So we have to look after them. Then we have plague which has already a history. We have rabies. Unfortunately, around 15 to 20,000 people are dying every year in India. We have, vaccination which is costing so much. So, it is just because of the way we are handling the dogs. Brucellosis, Japanese encephalitis, Kala-Azar, they are well-known public health problems. So these are very simple things which you know that the viral, bacterial, bacterial, and then protozoal, helminthic, fungal infections are because of various pathogens, and they are linked to animals. The different animals are involved, like the cattle, rodent, cat, dogs, fish, livestock, and birds. So we have linkage animal to man, man to animal, and in both direction. So that is there all the time because we all are, there. So this reservoir which are there as a human, or one must see that even the human being is transmitting the infection. So the factors are many which are increasing in number and increasing in intensity, which is the ecological factor. We are going into their territory and disturbing them, so they are going to create problem to us. Then issue of eradication, the effect of human, some diseases are already eradicated or decreased, so other become important. Then we have a human settlement, again, that is because of the disturbance of the symbiotic situation or symbiotic relationship we have established, which I think for more than 100 years we are studying the relationship between different living organisms. Then fluctuation, which is now increasing because of climatic change, which is now a reality. And the disaster, again, man-made and human or the natural, they are also occurring and becoming more intense. So because of that, the zoonotic diseases are increasing in number and leading to so much problem to the human being. That is why One Health has come. So I will speak very little, because if you understood, I think actions is already there. So it's an integrated, unified approach to balancing and optimizing the health of people, animals, and the environment. So I can recall myself when we were, reading the preventive social medicine, then public health, then, community medicine. It is agent dose environment, which is actually the epidemiology. What is new? Nothing. Just a new term all the time, created by some people, and then everybody start talking about it. It's nothing new, sir. Agent in host environment is there. Epidemiology, you cannot think without animal that disease will not occur or disease is not there. So we have to take care of. There is nothing new. That is why it's just a tool. Once again, re-emphasizing that you have to give importance to it. So we have to promote the animal welfare, to consider animals experiencing during a disaster. So whenever disaster occurs, it's a human and an animal issue. I say that whole disaster is actually a human problem. It's a health problem. I just can enumerate all the effects. I say it's a 7D effect, which is disease, disability, deaths, and disruptions of human environment, which is again lead to problem. So all just human issues. So health has to be an integral component of it, and health without animal is not possible. So therefore, this One Health, which is actually a human health and environmental health and animal health, they are part of all the things. Rather, I will try to add into it as spiritual or maybe I think mental health, which is more important. Should not disturb this whole machinery of the nature. So this prevention is important. Fortunately, the many organizations come together and they are now, making efforts that yes, we cannot work in isolation. We have to work together. So the NCDC is now here. We have the NIDM. We have the. I think if it is not there, it's a fault of us. If the animal husbandry or dairy and fishery people are not here, or if the veterinary people are not there, then I think somewhere we are not completing a task when we talk about disaster and emergency preparedness. So these people should be part and they are coming together. Then we are making the whole program and plan in a much better way. The vaccination, when we talk about human, at the same time we talk about animal also. And we have already realized as far as the rabies is concerned. Similarly, reduction of the bacteria, so source of infections, or maybe environment modification, which is required for the climatic change, and a climate dealing is also very important when we talk about disaster. And at the same time, the animals. Then use of advanced technology is a very important issue. Now we have to come up with this. Similarly, the food hygiene and local national surveillance, where again the public health preparedness play a significant role. Then we have like IC at the all level, then training of health providers, the operational health issues again. Not only the people involved in the disaster, but the people who are providing the rescue is also their health is very important, and at the same time other things. So these all are well-known facts. I think action is required, and action is without leaving anybody. If you leave anybody, I think you are not going to be successful. So this is what I want to say. Thank you very much.
Thank you, Professor Kishore, giving the nice presentation, including why we have gone for the One Health approach. Friends, we are behind the schedule. Time is very short. I am opening all the 4 topics for discussion. Particularly, we like to have 2-3 questions. So all the 4 topics are open for discussion. Any questions, comment on any topic, welcome. Then the speakers can give the reply. Any questions? Professor?
I'd like to add that the Ministry of Animal Husbandry has already taken action. They have made the plan. And some of the states are doing excellent job for creating the One Health, especially Bihar has done a lot for annual disaster management plans and the training of the veterinary doctors. And what is really required and now initiative from the Ministry of Health? because animal husbandry, in fact, I had discussion with Secretary Animal Husbandry. They have done a lot of work and they are quite keen to go for One Health. But I think Ministry of Health has to now take initiative. Thank you.
Thank you, sir. That was a wonderful question. And I take the privilege on behalf of NCDC because One Health as a guided, we have started the journey. We are around 15 years back. And a lot of work has already taken place. Now even in integrated disease surveillance program, when we talk about the rapid response teams, we have a veterinary officer in each and every outbreak. So that whenever we are looking into that outbreak, the veterinary officer can take control exactly what are the animal impact and what are the impact on humans. So there is a combined team that goes into a particular outbreak, and we don't just stop over here. We also have the animal labs which are contributing to the animal health, and that they are also sharing their reports with the, whether it is a human at the IDSP level, whether it is for the LCDC. So that we know exactly what kind of diseases that has been happening in the animal health. So those kind of bridges and the convergence. Yes, sir, we agree to you. A long way to go. Thank you, sir. Yes, please.
I'm Dr. Nitish Dogra from Delhi. I think this is a general question. This was actually raised by Dr. V.K. Paul also regarding in disaster situations, how do you use your human resources? And that particular point he said about medical schools or medical colleges. Now, besides the medical colleges, we also have a system which is less formal of our public health education. And right now, every year, I think approximately 2,000 public health graduates are passing out from various MPH courses. Even during the pandemic, we saw that hardly anyone was involved in such capacity. Such a huge human resource, and they could have been involved in so many ways in non-clinical activities. That I think is a very big lacunae, and I really appreciate comments on how the public health cadre in this country is going to be integrated. I'm not talking about community medicine. This public health cadre, what are we going to do about integrating them with disaster management?
You can tell there was a committee set up in which he was a member. You can reply then Dr. Pradeep.
Thank you, sir. In fact, with the commission, after this, I'll just like to make 2 comments more. Public Health Management Cadre was actually again released by the Honorable HFM 16th of April this year. So we have in fact made 4 cadres in that. And again, when I say 4 cadres, it means that they are in silos. They are also permitted. So one is the teaching cadre on which we, of course, HSRC did not work much. It's just mentioned as the teaching cadre. That's the NNC's prerogative. Specialist cadre, the public health cadre as such, and health management cadre. These 3 cadres are there with assured career progressions, and also as per required, if someone achieves a qualification, they can move to the another cadre as such, depending on the qualification they have. So the qualifications all have been listed. We made 5 or 6 such nomograms and all in each state. So each state has a different level of as such to create this. And these will be assured sanctioned posts. Like NHM has got 4.5 lakh now with 95,000 CHOs. There's almost 5.5 lakh contractual posts which started from 2005. But again, it's time now to move to sanctioned posts. That will also push the states to spend at least 8% of their budget in health. So these posts will have sanctioned posts. They'll be part of the system as such permanently, and it will be easy to monitor also. And people will also know that there is a system for that. So that's one. I think I've replied to the question. Just 2, sir, with your commission. One is that Dr. Naveen mentioned about the Public Health Act. This last 1 year we've had 3-4 meetings, and Mr. Love Agarwal is steering it now. So we are working with him, and we constitute a small subcommittee also. And we are now going to have state consultation with states. The document was huge when I joined last year. We have tried to prune it down. We are not mixing the act and the rules which was there earlier. We trying to separate that. So the act is very small and easily readable and implementable. Others for NIDM, when you talk of capacity building, we have made we do a lot of capacity building in a cascade model, national trainers, state trainers. but the quantity as well as the quality is always a question. So that's why we come up with the software, Sashakt, which is going to be launched very soon, and it is available. In case you want, you can take that software. It's just the names of the, like we have it for to monitor the training for the MO, staff versus CHOs and so on. You can change the categories where you want to do capacity building and that same software instead of creating it. Thank you.
Thank you, sir. Just for the COVID, what sir had just said, during COVID, to my remembrance, around 170 or 178 central teams were deputed, wherein we had asked the medical colleges to kindly complement us, and Dr. Sir will agree to me that there were a lot of people from the medical, especially from the public health background, who were there part of the teams. So this was just maybe the tip of the iceberg. But health being a state subject, and these people were already put into, especially not only the MPH people and the public health people, there were people from the final year students also. They were also requested to come in and to work for COVID-19, for which special incentives were given from the Government of India side. So that was there. That was just a supplement and information to the group.
Any, yes, please. Mic, please.
I'm P.R. Sharma. Is not the population explosion the main cause of most of the disasters? Is there any provision to check it? Until unless we check it, how can we? We never talk about it. There are so many things, but the main reason we never. Yeah. Population is actually problem is considered in terms of the area, per kilometer, how much population is there. Then we say it's a big or not. But we have Japan, which is having more population per kilometer as compared to India, which is still around 400. They have around 20,000, 25,000. So it's nothing to do with the population. I'm sorry, it is nothing to do with the population. It is the quality of the people. It is the quality of people. If our people are educated and they are more skilled, they will be the force of the whole world. So don't blame on the population as such an explosion. Mindset of the population. So it's a depend on the government to train them. Government to train them, not to blame, but to just not to blame the population.
I think we accept the comment that is needed. Any other question? Yes, last question.
Just a comment, sir, not a question. Sir was talking about the skill of the people of the country. I would like to say that we had MBBS students at Haryana during the COVID-19 period, and we were very confused how to use them because they were not skilled. So, if we will expose them to the patients, then probably they will also be infected, and that can be more disastrous. So, once we rope in people, like we trained people from Red Cross, so we roped in them, they went home to home, and we trained the lab technicians, they took swabs. So we train people in many ways, but the training part is very, very important. Before exposing the medical students, especially, into the disaster. So, just a comment.
Thank you. I think before we end this discussion, I request Mr. Gurjia,
Thank you, Dr. Sivlal and Dr. Pradeep and all the participants. So I will not be in between you and your lunch. I'll take only 5 minutes max, that I can promise. So it was a very engrossing discussion, and I have tried to capture some of the points. So basically I am trying to capture from the building blocks to how to strengthen public health system and disaster risk management system. And if we see that, probably I think risk governance has come up as one of the important recommendations from the speakers, and even the question which was mainly focused on laws, regulations, policy, plans. So most of the speakers touched upon that area. And I think having a robust policy framework supported by regulations and law is very important. So that has come out very, very clearly. Second thing which also came up under the governance is about the risk and changing nature of risk. Particularly we have seen during the pandemic, COVID-19, during which also some of the natural hazards hit the country. So that linkages between natural hazards and public health, when the system get overwhelmed, how you build your systems. And some of the speakers talked about capacity building. But then that capacity building and risk-informed planning has to go hand in hand. So that has also come up very clearly. The second very important key takeaway from this session is about risk-based approaches. And most of the speakers talked about breaking silos, particularly Professor Jugal Kishore talked about how various disciplines, various government agencies, we are a federal system, we have so many complications. So how do we break the silos? And that's I think was also coming up globally and nationally when disaster management system evolved in the last 3 decades, not only in India but also globally. So breaking silos is a big challenge, particularly in a governance structure, democracy with federal system, with so many stakeholders and players around. So probably I think joint planning, joint training and joint simulation exercises could help in breaking silos to start with supported by law and policy frameworks and standards and benchmarks, which I think is one of the greater learning for me that we have now the latest Indian public health standards, which talks about not only about a refined response but also about having quality assurance, moving from input-based to output and outcome-based, result-based systems and all those things. So these are some of the learnings. The last point which I noted is about the surge during any big disaster or when there is a pandemic and a disaster or a big pandemic like COVID. How do you institutionalize a system of surge, which came up for discussion? I think in disaster management, we have some inbuilt capacity in terms of National Disaster Response Force, State Disaster Response Force, fire service, civil defense, and so many specialized forces. I think we have to build that kind of capacity, integrate with the public health service providers, and create some kind of a system where you can easily deploy. As we have seen during COVID-19, that no country in the world was able to manage within the resources which were directly available. So any system can get overwhelmed during a public health emergency and disaster. So how do you have a system of surge where you can deploy additional resources? Where do you mobilize those resources? So that kind of, I think, plan should go beyond, from planning to action planning and have a system of surge, not only in terms of human resources, but also in terms of equipment, which we saw particularly during the, second wave of the COVID in the country, that many of the critical equipment and resources were getting overwhelmed. So these are, I think, 3 major learnings from this session, which I think the organizers will take forward for further discussion and refinement and suggestions to the various stakeholders. And then I would like to thank the organizers, NIDM, NCDC and CBC for inviting me from USA and providing this platform. Thank you very much.
Thank you. Session is ended.
On behalf of the organizing team, I am very grateful to the chair and co-chair of the thematic session 1 of the Emergency and Disaster Management System. So definitely we will take the key comments and the suggestions which are deliberated during the session, and we will make a note of it. And before concluding the session, I request Professor Surya Prakash to present a token of appreciation to our co-chair, Dr. Silver Bronson. Yes, sir, Chair. Now, I request Dr. Dr. Rajiv Sharma to present token of appreciation to our co-chair, Shri Arun Sahdev from USA. Now I request Professor Srinath to give a token of appreciation to our co-chair, Dr. Pradeep Kashuri sir, DDG DM sir, Minister of Health and Family Welfare. I request all the distinguished speakers to get on the board so for a group photo and a token of appreciation. Now I request, I humbly invite Major General Professor Atul Kotwal sir onto the dais. And I request Dr. Sivlal sir to give a planter to the Now I request the co-chair of the session, Dr. Shri Arun Sahdev sir, to give a planter to Dr. Naveen Verma. Now I request the co-chair of the session, Dr. Pradeep Kashuri sir, to give a planter to Dr. Surya Prakash sir. Sir. Now I request the chair of the session, Dr. Sivlal sir, to give a planter to Professor Jogal Kishore sir. Now I request all the chair and co-chair and distinguished speaker for a group photo. Thank you, sir. Thank you once again for your valuable deliberation in this session. Yeah. Now we will join for the lunch break and we will rejoin here by